and good evening to our honorable speakers, chairs, and audiences of the ACNS webinars in different parts of the world. We are back again with another session of very interesting lectures for you. The speaker for the first session of today is our honored guest from Turkey, Professor Mehmet Zileli. Professor Zileli is a professor of neurosurgery at Department of Ege University, Izmir, Turkey. He was the past president of the ACNS and also the past president of the Turkish Neurosurgical Society, Middle East Spine Society, and World Spinal Column Society. He is the current chairman of the WFNS Spine Committee. His surgical expertise is focused primarily upon spinal injuries, degenerative spine conditions, spinal column corrective surgeries, and spinal tumors. He is a renowned faculty in the world of global neurosurgery education and is an invited faculty to several workshops and conferences around the world. He is a noted author with contributions to several book chapters and articles in various peer-reviewed journals. We are extremely honored to have him today as a speaker at our webinars, and today we'll be talking about cervical spondylotic myelopathy and OPLL and update. The speaker for the second session of today is our honored guest, who is from Brazil, Professor Igor Facchini. Professor Facchini is the chairman in the neurosurgical department, IMIP Rafice, Brazil, and he is also an assistant neurosurgeon at the Hospital de Restauração, University of Pernambuco, Rafice, Brazil. He is a member of Brazilian Neurosurgery Society and Pediatric Neurosurgery. His research interests are focused upon cerebrovascular and pediatric neurosurgery. His center is one of the renowned centers for performing intrauterine closure of myelomeningocele surgery. And we are extremely honored to have him today as a speaker at webinars. And today we'll be talking about intrauterine myelomeningocele repairs, surgical techniques, and experience of a referral center. The chair for the first session of today is our honored guest and senior faculty from Turkey, Professor Onur Yaman. Professor Yaman is associate professor at the Memorial Healthcare Network, Istanbul, Turkey. His clinical practices focus mainly on spine surgery. He is a member of several important organizations, including the Turkish Spine Society, Middle East Spine Society, World Spine Column Society, Eurospine, AOSpine, and SRS and Scoliosis Research and Treatment Association. He has won numerous awards throughout his career and is a noted researcher with several publications in various peer-reviewed journals. We are extremely thankful to him for agreeing to chair the session of Professor Mehmet Zileli. The chair for the second session of today is the honorable senior faculty from Germany, Professor Concezio Di Rocco. Professor Di Rocco is the director pediatric neurosurgery at the INI, that is International Neuroscience Institute, Hanover, at Otto van Guericke University, Germany. He is also a consultant Department of Pediatric Neurosurgery at the Catholic University Medical School, Rome. He was the past chairman of the Education Committee of the WFNS, and he was a chairman, director together with Professor Chokes of the International Master Course of Chinese Pediatric Neurosurgery, Beijing. He was the past president of the ISPN also, and he has written several articles in reputed journals and book chapters. He is current editor-in-chief of the prestigious journal Child's Nervous System. We are extremely grateful to him for accepting our invitation to chair the session of Professor Igor Facchini. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the distinguished audiences to this online platform of ACNS webinars. Dr. Lubun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this virtual podium to our first chair, Professor Onur Yaman.
Dear colleagues, dear friends, hello to everyone. First of all, I'd like to take to ACNS organizing committee for this kind invitation. And to special thanks to Professor Yoko Kato, Hubin, and Dr. Raja. So we have today very variable speakers here. And the first lecture is about cervical spondylotic myelopathy and OPLL. The main questions in cervical spondylotic myelopathy and OPLL is the clinical presentation, the scores defining the severity of the disease, the natural course of cervical spondylotic myelopathy, the diagnostic tests, and the value of the surgery and non-surgical treatments, and also the surgical techniques. So the first speaker is Professor Dr. Mehmet Zileli. He's my mentor, and if Zileli is ready, please, Zileli.
Thank you a lot for inviting me to this wonderful conference. The title of my talk will be Cervical Spondylotic Myelopathy and OPLL, and I will try to update our current knowledge on that subjects. It's still a challenging subject, and WFNS Spine Committee has done a recommendation set about this subject by 2 consensus meetings. They are also already published in 2019. This is, if you wish, you can see the details of our recommendations in that website. Besides that, we created a book, WFNS Spine Committee book on this subject. It is just published this year, and it is with team publishers. You can find the book. My presentation order will be dealing with first clinical presentation, then natural course, and electrophysiology, the radiology, non-operative management of mild CSM, and operative management of severe and moderate CSM, and anterior versus posterior surgery options, and prediction of outcomes and conclusions. And then I will give some other data about OPLL. If you look at the clinical presentation, it is all well known that myelopathic signs, hyperreflexia, inverted brachioradialis reflex, Hoffman sign, Babinski and Clonus are integral part of clinical diagnosis. However, they may be absent in about 20% of myelopathic patients. And the natural course is very variable, but progression of the disease is possible, but to predict which patients will go to a progression of the disease is not well known. Some patients may remain static for lengthy periods, and some patients with severe disability can improve without treatment. We have already seen many such cases, but the real numbers are not well known. For patients with no symptoms but having significant stenosis, the so-called pre-myelopathic patients, risk of developing myelopathy with severe cervical stenosis is approximately 3% per year. So then in very elderly patients, in 10 years period, they will have 30% of progression. What about the role of electrophysiology? Electrophysiology tests are commonly used in CSM patients, and in order of benefits, we can count on motor evoked potentials, then spinal cord evoked potentials, somatosensory evoked potentials, and electromyography. Routine tests are useful in differential diagnosis of CSM from other neurologic conditions, especially the polyneuropathy and anterior horn disease, ALS. However, these differential diagnosis is very difficult in the early period of those diseases, and the tests are necessary. Specific tests are necessary, and mild forms of ALS and polyneuropathy may not be differentiated easily. Although MEP and SEP have been found as valuable tests, there is no evidence that they are more valuable than clinical parameters. What about intraoperative monitoring? As you know, many people are using intraoperative monitoring with electrophysiologic tests. We know that in ACDF surgery, it is questionable or not very valuable. It is found EMG and MEP monitoring have been found to be useful to decrease the C5 root palsy during CSM surgery. There is good evidence in the literature, and intraoperative MEP SEP changes do not necessarily prevent neurologic injury and improve the outcomes. We can also use this sentence for all intraoperative monitoring. Actually, it is possible with a good collaboration of monitoring team and the surgeon himself or herself. What about the radiology? In spite of conflicting evidence, the best test looks like the magnetic resonance imaging. Among the many variables in the MR, compression ratio, maximum canal compromise, and transverse area measurements are the most importantly correlated with functional outcomes following surgery. So we must try to measure those tests. What about T2 hyperintensity? If there is an intense spinal cord T2 hyperintensity on cervical MR, the outcome of those patients are worse than the others. Patients with lighter signal changes on T2 on cervical MR should not be excluded from surgical treatment. On the other hand, T1 hyposignal is a worse outcome predictor than T2 hyperintensity. There are different classification methods about the hyperintensity, but this one of you and co-workers from 2015 is the most often used test. There is a type 1, type 2. Type 1 is the diffuse pattern of intramedullary T2 hyperintensity with a faint border. However, type 2 and type 3 is a focal patterns of intramedullary T2 hyperintensity. In one of them, it is with faint borders. The other one is sharp borders. If it is sharp, then it means it's a cavitation or atrophy, possibly. There are new imaging techniques like diffusion MR, MR spectroscopy, and dynamic MR. They may be a part of MR examination, but there is currently not good clinical correlation studies, and we strongly suggest to use them in outcome studies and see if they will be more valuable in prognostication of CSM patients. What about the non-operative management? Is there a non-operative management, or it is just follow-up? Actually, we now classify CSM according to the modified Joan scores. If it is between 15 and 17, we call them mild CSM. If it's 11 and 14, we call them moderate. If it is less than 11 points, it is then severe. There is no doubt about severe and moderate CSM patients. We must suggest a surgery for them. However, for mild CSM patients, a rehabilitation or non-operative management should be recommended. Non-operative management may be considered for slowly progressive disease also. If those patients develops a rapid progression of symptoms, then we recommend a surgery. And if those patients get a radiculopathy during their disease period, then we also recommend surgery. Non-myelopathic patients with radiologic evidence of cord compression, but without signs and symptoms of radiculopathy, should not be offered a prophylactic surgery. But we must have an informed consent from the patients about the possibility of the neurological deficits development following a mild injury. They can struck their heads somewhere, or they can fall during walking, and then they can develop tetraparesis. This is a possibility. We must inform them about that. But non-myelopathic patients with radiculopathy, they are good candidates who may deteriorate, and we are recommending a surgery or close observation with rehabilitation if the patient refuses to undergo surgery. But it's better to go a surgery. What about the value of surgery? in general saying, lack of evidence for the value of non-operative management, but there are predicting factors that deterioration is possible during non-operative management. These are circumferential cord compression and axial MR, reduced diameter of CSF space, hypermobility of spine segments, angular edge deformity, instability, segmental lordotic angle if it is low, and if there is additional OPLL, and if there is there are symptomatic radiculopathy, if the NEPs and SEPs are prolonged. Another important issue is that the duration of the symptoms. If it is very long, then we will not expect good outcomes. What about the options of operation? Surgical treatment, persistent or recurrent radiculopathy, non-responsive to conservative treatment, must go to surgical treatment, and progressive neurologic deficit patients must go to surgical treatment. Static neurologic deficit with severe radicular pain must also go to surgical treatment. What about the type of surgery? There are many options for anterior decompression, such as ACDF, ACCF, corpectomy and fusion, oblique corpectomy, skip corpectomy, and hybrid surgery. A corpectomy is a good option for ventral compression less than 3 vertebral segments, or if there is some kyphotic deformity. In case of multi-segment disease, if it is more than 2 levels, it may be better to go from backwards, posterior surgery. In the past, we have used corpectomy grafts by placing grooves on cranial and caudal sides and without placing any plate. But currently, it is our routine that with 1 or 2 level corpectomy, we always place anterior plates. And if it is 3 or more level corpectomy, we place anterior plates, plus we add a posterior fixation. This is a case of 2-level compression with T2 hyperintensity. We have done a 2-level corpectomy with graft and plate. But if it is more than 2 levels, this slide is from Dr. Ed Benzel. If you don't add a posterior fixation, then the plate may dislodge and the long graft may go backwards, like you see here. There are so-called kick-out plates for those instances, but they don't work well. So anterior corpectomy more than 2 levels. If it is more than 2 levels, posterior fixation must be added. What is the alternatives for that? If you make a skip corpectomy, it can prevent you to make a posterior fixation. If you make an oblique corpectomy, it prevents any fixation. I will give you some examples. Yes, this is what the skip corpectomy is. Then you leave one body in between upper and lower levels, so then you can make some osteophyte resection from both upper and lower levels. And by a lordotic plate, you can achieve a good lordosis by moving the left body ventrally. This is so then this is so-called skip corpectomy, and it prevents posterior fixation. One thing is that anterior surgery may have more complication rates. Some of them are site-related complications, which are most common, like dysphagia and hoarseness. There are graft-related complications, graft dislocation, pseudoarthrosis, adjacent level degeneration. or graft site complication if you harvest a graft from somewhere else in the body. Reported complications are mostly approach-related complications, but neurologic and implant-related complications follow it. What about oblique corpectomy? And this is an approach first described by Dr. Bernard George. It is no fusion is necessary, no significant instability. However, it may be technically demanding. Vertebral artery injury may be a risk. A Horner syndrome may develop. This is one example. Although there is some mild kyphosis, I have chosen an oblique corpectomy. You can see how did I do it from this part of the body has been removed. Another note is about the CSM in elderly. CSM may manifest at higher levels in the elderly because the lower levels may go to bony ankylosis and spontaneous fusion, and especially C3-4 level, or sometimes in the lower levels like C7-T1, the CSM may develop. What about success rate of anterior surgery? It's about 70 to 80%. There is no significant difference of success rates with ACDF, ACCF, or oblique corpectomy. ACDF is generally associated with less intraoperative blood loss and less operative complications than ACCF. There are several factors that should be considered for selection of surgical approach in CSM. One is the cervical curvature. If it differs, it makes a big difference in our decision making if it is lordotic or kyphotic or preserved lordosis. Locations of the compressive pathology and the number of levels involved and the patient's comorbidities are very important decision makers. Another one is the measuring the cervical sagittal balance. This is C2 plump line, and this is C2 C7 SVA measurement. If it is more than 40 millimeters, we will expect poor functional outcomes after cervical laminectomy. And there is a good relation between cervical alignment and global spine alignment. So we must have concerns about achieving a good global spine alignment after our surgeries. Otherwise, the patient may be disabilitating because of head position and not able to see the faces of others. What about postural surgery? In general, we can say laminectomy alone, laminectomy plus fusion, and laminoplasty. Probably we must skip laminectomy alone. This is not a good option because there are cases with laminectomy alone. Laminectomy membranes, so-called fibrosis, or post-laminectomy kyphosis may develop. So then there are mainly two options, laminectomy plus fusion or laminoplasty. Sorry. In kyphotic cases, if it's a flexible kyphosis, laminectomy and postural fixation must be preferred. If it's a rigid kyphosis, anterior surgery with a posterior decompression may be preferred. If the lordosis is preserved, laminoplasty is a good option. Cases with severe axial neck pain should not go to a laminoplasty because in general saying, there is good literature reports about that after laminoplasty, the patients may have more axial neck pain than laminectomy plus fusion. There are always gray zones, such as straightened cervical spine, that we do not know for sure which approach is better. And multiple factors must be taken into account when deciding on the operation for a particular patient. Surgeons need to tailor their preoperative discussion to alert patients about these facts. Postural surgery has advantages, a very good technique for decompression of structures. However, increasing instability resulting in osteophyte formation, hard disk and anterior osteophytes cannot be removed with postural surgery. Neurologic complications of postural surgery are somewhat higher than anterior surgery. There are absolute postural surgery indications, like the case you see here, C2-3 facet hypertrophy and very narrow canal. You cannot do it without a postural surgery. Or if the case is a hyperlordotic and diffuse narrowing, like you see here, this patient is also a good candidate for posterior only surgery. However, the case like this, there are both posterior and anterior compressions, and it is a diffuse, and lordosis is preserved. You can both make a surgery from anterior or posterior. There are still some discussions which one is better than the other one. We have done a posterior surgery for this case. Yes. Lateral mass fixation is currently very often used. And the other one is the laminoplasty. As you know, there are two main openings. One is unilateral opening, which Hirabayashi was first described from Japan. Then since the hinge was closing by the time, some other surgeons have developed bone graft placing, and then even a plate placement here. Bilateral opening is technically more demanding, more difficult surgery. Again, they can get closed afterwards, and so then a bone graft may be placed in between. Yes. What about complications of postural surgery? Injury to the spinal cord and nerve roots, C5 palsy, as I said before, it is more common than anterior surgery. Implant-related complications may develop, spring-back closure of lamina, and post-laminectomy kyphosis, if you don't fuse backward, may develop. There is a trend towards laminoplasty in comparing laminectomy to laminoplasty, being better than traditional laminectomy, but relatively equivalent to newer techniques of minimally invasive skip laminectomies, and especially micro endoscopic laminectomies. There is a new trend. What about combined surgery? Patients with kyphosis and long segment disease may be a good candidate for combined surgery. I will give you one example. This case had one big disc herniation at C3-4 with hyperintense zone inside and diffuse narrowing at the lower level. So then I decided to make a anterior posterior surgery. This is after laminectomy, did a posterior lateral mass fixation, and C3-4 discectomy plus allograft fusion. This is the post-op MR image. As you can see, there is no disc herniation, and the canal is quite well. And here is the T2 hyperintensity still resist there. What about the prediction of outcomes? Can we predict which patients will go better outcomes, which patients will not? There are a variety of outcome measures used for CSM. As functional measures, we recommend Modified Japanese Orthopedic Association score, NURIX grade, and Myelopathy Disability Index are the tests we are recommending for spine surgeons. Clinical variables predicting outcomes are age, duration of symptoms, and severity of the myelopathy. These are very much related with the outcomes. Older patients may have worse outcomes. Symptom duration, if it is more than 1 year, it is worse. And severity of the myelopathy, if the Joule scores are less than 11, the outcomes are worse. If there are hand atrophy, leg spasticity, and Clones and Babinski signs, examination findings, and they are also bad predictors. What about the radiologic variables? Curvature of the cervical spine, kyphosis versus lordosis preservation, instability is a worse outcome predictor, spine cord compression ratio, spine cord atrophy cannot predict outcomes. High signal intensity on T2 is a negative predictor for prognosis. Surgical variables, if anterior compression is more than 2 levels, or if it is diffuse narrowing, posterior decompression should better be chosen. If CSM is the most important factor on decision making is cervical sagittal vertical axis. If, as I said to you before, if it is more than 4 centimeters away from the C2 plumb line, they have worse outcomes. In conclusion, if there is a focal disease, focal surgery like ACDF may be a good option. If it is a diffuse disease, diffuse surgery, if it is anterior, multi-level ACDF or corpectomy or oblique corpectomy are good options. If it's, but laminectomy plus lateral mass fusion or laminoplasty are also good options. If it is less than 2 level, multi-level anterior compression, multi-level ACDF, if it's at 2 levels, especially if it is also in the body levels, corpectomy should be chosen. If it is, however, more than 2 levels, 3 or more, laminectomy or laminoplasty should better be chosen. For multi-level diffuse disease, if there is no kyphosis, laminoplasty or corpectomy. If there is a kyphosis, we should always do a corpectomy anterior surgery. With proper indications, results comparable with either corpectomy or laminoplasty, higher complication rates with corpectomy, oblique corpectomy may be an option for selected cases. These are my conclusions to give you at the end of this session. I will talk a few about the OPLL. As you know, there is such a classification, although there is this classification, it doesn't mean much, I must tell. This is a case with OPLL and also ligamentum flavum ossification together. Anterior surgery of OPLL cases has advantages like direct decompression of the pathology, better correction of a kyphosis if there is. However, higher risk of neurologic injury and higher risk of CSF leakage. Dysphagia and hoarseness, particularly in elderly people, may cause us not to decide an anterior surgery in elderly. Difficult to go anteriorly if C2 and T1 levels are involved. Difficult if more than 3 levels are involved. What are the options for anterior surgery? There are, as we mentioned in the CSM, anterior cervical discectomy and fusion for segmental OPLL, corpectomy and fusion for continuous or mixed OPLL, floating corpectomy, if OPLL is densely adherent to the dura, if we notice that in before surgery films, actually with a thin section CT scans, we can see a dural involvement of OPLL. Another new technique is anterior controllable anti-displacement and fusion surgery, which our Chinese friends have introduced and improved if OPLL is densely adherent to the dura. This is the floating corpectomy. Actually, you do a corpectomy, you come to the OPLL, and you drill it partially, but you don't remove it all parts. The last membrane, you leave it on the dura. And then you expect, since you have decompressed lateral parts of it, you expect with CSF pulsation, it will go forward. And then the compression of the spinal cord will get decreased. Another one, similar to this, is anterior controllable anti-displacement and fusion, first described by Sun and co-workers in 2018. So you make a lateral drilling of the bodies and also excision of the upper part and lower part of the disc. And you then place a lordotic plate, and then by this plate, you then draw all the bodies together ventrally to the plate. So then the canal decompresses without touching the OPLL on the back of the bodies. This is the technique. Laminectomy, it is almost left due to risk of developing kyphosis. Laminectomy and lateral mass fixation can be done, and laminoplasty can be done in OPLL patients. There is a so-called key line. This is the line joining the midpoint of cervical canal at C2 and C7 levels. So if this key line is passing through the OPLL, so in those patients, we call it key line negative. If it is seen, then this patient will not benefit from a laminoplasty or laminectomy plus fusion surgery in key line negative patients. But in key line positive patients, the patient may benefit from posterior decompressions. Again, I will repeat that measurement and this one. And laminectomy and fusion, we almost always apply C3, 4, 5, 6 lateral mass screws, but C7 pedicle screws. If it's necessary, also C2 pedicle screws. Patients with kyphosis and long segment disease, we make a combined surgery. Which surgical approach is better than the other? There are many studies in the literature. This one is from 2017, a Japanese group, a meta-analysis of 6 studies, and postoperative Johann scores of anterior surgery was higher. However, anterior surgery had significantly more complications, they reported. Another one from 2011, 27 retrospective studies, a total of 1,500 cases, and the overall incidence of surgical complication in OPLL patients was found 21%. And anterior approach is not statistically different than posterior approach. the incidence of complications. What about CSF leakage incidence? Studies using single anterior approach is about 11.9%. However, in posterior surgery, it's 2.7%. It's quite common. Actually, if CSF leakage happens from ventrally in the cervical spine, it may cause significant swallowing difficulty and even breathing difficulty, respiratory problems. Again, a meta-analysis from 2018, laminectomy alone 6.2%, anterior decompression and fusion 11% incidence of perioperative complications. And they also say anterior surgery has more perioperative complications. This is from our Korean France paper, which has examined for a long period with a posterior fixation surgery, the OPLL can resolve inside the canal. In conclusion, in OPLL, anterior surgery if 1 to 2 levels are involved, posterior surgery if more than 2 levels are involved. Outcomes of laminectomy and fixation or laminoplasty are similar. Laminectomy plus fusion may be more appropriate to stop the progression of OPLL. This is with new studies. So, especially in the younger patients, you can prefer this option instead of laminoplasty. However, in older patients, since we will probably not see the progression of OPLL in the older elderly, you can make laminoplasty. And postoperative JOA score of anterior surgery is higher, better. Anterior surgery has more complications than posterior surgery. In posterior approaches, C5 pulse and axial pain occur more frequently. However, in anterior approaches, CSF leakage, implant complications, hoarseness, dysphagia, and dyspnea may appear more. Floating corpectomy or anterior controllable anti-displacement and fusion are new techniques for anterior decompression of OPLL. 14% of the patients with cervical OPLL require an additional surgery due to multiple lesions, especially in lumbar area. We must have concerns about the existence of OPLL in other areas. So I will repeat my first mention about the WFNS Spine Committee recommendations in our website and of our book. I will promote our book. Thank you for listening to me. This is for İzmir, Turkey and Istanbul Spine Masters in next year in February 24 to 26 in Istanbul. Thank you for listening to me.
Dear Zilali, thank you so much for this great lecture. I'll take lots of notes here. Raja, can we see questions?
Yes, of course. We can invite questions. Yes, my co-host, Dr. Libun Singh, any questions?
There is a question here, Zilali, to you. If MRI cervical spine show core changes, myelomalacia, is this has any prognostic value? You have answered this question, but
yes, he has already answered that.
Yes, T2 hyperintensity is a worst predictor, but it may disappear after surgery. If it does not disappear after surgery, it is worse. If it disappears, probably because of cord edema, then the prognosis is not that much worse. Another one is the T1 hypointensity, since it may mean it's some atrophy of the spinal cord. It has worse predictor of outcomes than T2 hyperintensity.
Thank you very much.
I have a question.
Yes.
When the patient doesn't have any symptoms, I think the difficult case is that we have to decide if we have to treat this patient surgically. Because in your presentation, you have told that the non-symptomatic cases, the pre-myelopathic cases, 3% of them may progress to myelopathy. What's your algorithm there? Do we have to follow them closely? Because if symptoms are does appear, then does it mean if you're late for the surgery?
Yeah. If it appears, it's mostly mild again. It's not very severe. I didn't see too many patients I'm following and who have developed severe myelopathy by the time. But there are good series who have a good follow-up of pre-myelopathic patients and who had not developed any myelopathy in 10 years, 20 years. So then we do not recommend a prophylactic surgery for those cases. We can wait. And we can warn them about minor trauma and try to be cautious about minor trauma. And if they are very scared of minor trauma, then they can go to surgery.
Another question, Professor Zilili. How do we have to talk with the patients? Because they're thinking like they're only simple cervical disc hernia, and they think that after the surgery, all the symptoms will disappear after the surgery. So how do we have to talk with a patient that has a cervical spondylotic myelopathy? How do we explain the patient the benefit of the surgery after how can you explain it to a patient? Yes, yeah. Your pain will disappear after it. Your numbness will disappear in 6 months or 1 year, or do we have to talk according to the MRI signs? How do you explain to a patient?
Yes. Actually, there is a misunderstanding of what disc herniation is, what cervical spondylotic myelopathy is between these surgeons. There is a misunderstanding. So then even they can define, a neurosurgeon can define a patient with cervical myelopathy as a disc herniation. It's not good because disc herniation is a radicular symptom patient only. And it is mostly in younger patients, and the patient has a brachialgia. However, cervical myelopathic patients are usually older patients. They have 1, 2, 3, 4 levels, narrowing and myelopathic signs mostly. I mean, spastic tetraparesis, some atrophy in hands, and Hoffman reflex positivity, other things. In such cases, if I talk a patient about the outcome of surgery, I tell them there is if the duration of the symptoms are not very long, if they say, I have these symptoms for 2 years, 3 years, the difficulty in walking like this, I cannot give much promise. But if it is quite new, a few months only, I tell them there is a big possibility of improvement after surgery. You'll get better. 70 to 80%. The literature says 70 to 80% of the patients will improve after surgery. It is quite big. Which patients are not improving? I have given some numbers in my talk.
Zilali, another question from Harjat Parekh. Do you believe that all degenerative changes seen are secondary to facet instability?
Not just facet, actually motion segment problem. we must, motion segment is the disc adjacent end plates and on the backward two facet joints together. This is the motion segment. It's a disease of the motion segment. Yes, the body tries to stabilize that instability period problems with new bone formation or new osteophyte formation, and that osteophytes or new bone formation causes spinal canal stenosis. This is a well-known phenomenon.
Raja, do we
Yes.
have any questions?
Yes, I would like to add two questions to ask Professor Jalili. One question is, what is your experience regarding reperfusion injuries, especially with those who are dealing with OPLL and we are going anteriorly and we are decompressing the spinal cord with the floating technique of Yamamura that you showed earlier. Have you had any experience? Because we had a few cases where there is severe stenotic spine and we decompressed and the patient has a bad outcome. What is your theory behind
With
this?
the anterior surgery, am I right?
Anti-research, yes, anti-research.
Yeah, I have also a few. Yes, it is possible, but I don't think it is a reperfusion injury. I think it's a iatrogenic trauma to the spinal cord, because although we use very nice high-speed drills or other things, at the end, if we are entering underneath the OPLL, we are squeezing the spinal cord between narrow canal and our new tool. I think we are, on those instances, we are injuring the spinal cord. It's better to leave that part there and then wait for CSF, decompress it spontaneously by the time in very narrow canals.
Thank you very much.
Ronur, I want to ask a question.
Yes,
What a great lecture, Professor Mohammed, and very good educated lecture. Just one question. You told that anybody who has got a preoperative axial spine, they should be addressed from anteriorly. At the same time, I am asking if a patient has OPLL and also has axial pain and more than 2 segments OPLL. You told also more than 2 segments, it should be addressed posteriorly, but in the event they have axial pain and more than 2 segments OPLL, what will you do, posterior or anterior?
Posterior. And I will prefer laminectomy plus fusion instead of laminoplasty.
Will their axial pain will get worse after surgery?
Axial pain occurs mostly in patients. In 2 instances, axial pain you will expect. One is the laminoplasty, after laminoplasty. The other one, if you did not correct the sagittal balance.
Okay.
Actually, if those measurements are not corrected.
Okay. Thanks, Professor. Thank you.
May I add something?
Yes, please.
Zilali, you have mentioned the importance of sagittal balance. I think one of the most important thing, maybe the most important thing, is here the sagittal balance to decide the anterior or posterior surgery. C2, C7 SVA is important, and also the difference between cervical lordosis and T1 slope. The difference between it means the harmony, like in the global balance. You have to give the lumbar lordosis according to pelvic incidence in the global balance, but you have to give this harmony also to cervical sagittal balance, because if you get this difference between some gap, the difference between cervical lordosis and T1 slope, your success will greater after the surgery. And another thing that determines your sagittal balance as chin-brow vertical angle. If you get all them, if you get a proper cervical sagittal balance, as you mentioned, you will have less axial pain. This was my comment.
Thank you very much. We'll take one last comment from my co-host Liubun Singh before we move on to the second session.
Thanks, Raja. Thanks, Professor, for a very nice, comprehensive talk. Professor, I want to find out from you, in terms of correction of the cervical lordosis, do you always test patient before the GA, or you can do it after the GA with monitoring, or after corpectomy or laminectomy? My second question, Professor, do you, in those you say that with a long symptom usually don't have good outcome. However, do you think that it's useful to use steroid and the response to steroid to determine the outcome, the success of the surgery? Thank you, Professor.
Steroids for what? Usage of steroids after injury or without injury?
With symptom improvement with steroid, partial improvement with steroid will indicate better outcome. Do you think so, Professor?
No, I did not see good evidence in the literature about using steroids in cervical degenerative cervical myelopathy or cervical spondylotic myelopathy. There is no place of it. But in case of trauma, somebody may use it. If the neurologic deficits are very severe, after a minor injury, you can use it. There are some not very strong evidence, but light evidence. What was your first question? Sorry.
Yeah, to determine the degree of correction of cervical lordosis, do you do it before general anesthesia when the patient awake, or you can actually do it with intraoperative monitoring under general anesthesia, or after corpectomy or laminectomy? Which one is safer? Thank you, Professor.
It is not my routine to use intraoperative monitoring in cervical myelopathy because the results are very not very clear. But as I mentioned before, C5 nerve root palsy can be monitored. You can avoid it or prevent it. But I do it under general anesthesia. Before surgery, no, I don't.
Right.
Thank you.
Thank you very much. We had a wonderful lecture, and I would like to sincerely thank Professor Mehmet Zilili for this beautiful lecture, and Professor Onur Yaman for sharing this. And I would like to inform our viewers that this webinar is broadcasted across the WeChat, Zoom, and YouTube channel, and the WeChat channel broadcast has been arranged by our very honorable Professor Shubin from China, and we are extremely grateful to him for that. Currently, we are having around more than 500 people who have joined this webinar live. So we'll move on to the second session, and I will invite Professor Concesio Di Rocco to say a short introduction about intrauterine closure of myelomeningocele and invite Professor Igor Facundi for his lecture. Professor Di Rocco, all yours.
Good evening to all the people, especially to the speaker. And I think that we are very lucky to have him today for essentially for tourism, because in Brazil, the treatment of the intrauterine treatment of a myelomeningocele has a long history. Was one of the first countries where several people started to do this kind of operation, and in different centers. And there is a reason for this, because in Brazil, it is not allowed the interruption of the pregnancy. So the family has to face the problem to wait after birth or to try to decrease the damage of the disease before birth. And this situation needs to have a third point, that is to have a neurosurgical technique advanced and sufficient to face this problem. And also, the myelomeningocele quite common in Brazil, as in other countries that do not enjoy folic acid supplementation, which happens in several countries, especially in developing countries. So we have the combination of needs of a developing country, means several malformations to take, and at the same time availability of a technique that can cover the problem, which is a very rare instance in the world. So I'm very happy to invite the people from Pernambuco, to invite Pasquini. Pasquini, the name I hope is Italian origin. I'm very lucky to invite him to present the good situation of this kind of surgery.
Oh, thank you very much. Grazie mille, professore. Italia in mio cuore. Thank you very much for the invitation. It's a pleasure to be here and an honor. So I hope we can share a little bit of our experience and knowledge about this pathology and this treatment. As Professor Di Rocco mentioned, we have some peculiarities here in Brazil that brings us to face this problem in a particular way, we can put like that. Once again, thank you very much for the invitation. And we're gonna talk a little bit about the intrauterine repair, focusing on surgical technique and our experience as a tertiary reference center in the Northeast region of Brazil. Oh, I'd like to thank to the ACNS webinar organizing committee and all the panelists, and I'd like also to congratulate Professor Zileni for the outstanding lecture about OPLL. So let's move on. It's very important, the knowledge about the physiopathology of myelomeningocele. It is a embryonary disease, and it establishes in the first 21st days of life, of embryonary life. And there is a mechanism of a CSF leakage through it. So you have the CSF leakage principle, and due to that, we will have the secondary lesions, the secondary consequences of this, that are mainly the Chiari-2 and also the hydrocephalus. So it all starts with the CSF leakage process. So we have this kind of negative pressure that brings down the cerebellum and also blocks the CSF flow in the upper region of the brain, and consequently we have hydrocephalus. So this is the main physiopathology of myelomeningocele. It is the most common spinal dysmorphism, open dysmorphism that we can face. So there are so many relevant issues in terms of treatment that we might consider. The first one is the ethical issue. The second one is the religious issue. And this is very important because you have different situations around the world. Also the social problem involved in this pathology, and also the emotional aspect of this pathology, especially concerning the mother. So we have the placodial exposure to the amniotic fluid, and that causes a secondary hit also in the nervous structures. So the main principle is that the early treatment up to the 26th week of pregnancy might improve the Chiari by closing the CSF leakage mechanism, and also consequently reducing the hydrocephalus and trying to avoid the need of VPS of ventricular peritoneal shunt in the postnatal period. So that's the rationale behind that. So the first case started to be done in the States in the second half of the 90s. Two groups almost at the same time published their first reports after a period of animal models studies. And in 1998, they published the first human reports, the first reports on human myelomeningocele surgery. It's also important to highlight the social economic disparities between countries and between regions inside the same countries, especially in continental countries like Brazil, for example. So here we have the Human Developmental Index, which brings us to an already disparity between developed and low-income countries like ours. So we have in the USA, the developmental index is 0.926, in Brazil is 0.76, but in our region, the Northeast region of Brazil, we are the poorest, one of the poorest regions of our country. Our index drops to 0.6, and if we look, it's even lower than the index of our country, which is 0.7. In the Southeast region, where we have São Paulo, our biggest city, the index is better, is 0.75. So this is very important because myelomeningocele is a disease that is correlated with poor conditions of nutrition and a low intake of several nutrients, mainly the folic acid. So it's also a social disease, we can put like that. So initially they started with also with the fetoscopy. Fetoscopy is something that we need to pay attention. It's going to develop a lot more in the next years as any new technique. But nowadays we have some limited results and only 2 or 3 main centers around the world. And we need to raise concerns about the cost and the availability of the endoscopic materials to perform it in low-income countries. So we need to look at this, but it is not the gold standard today yet for this kind of pathology. Well, literature also brings us some robotic assisted attempt to solve the problem, but the results were not good at all. And the percutaneous fetoscopic coverage in experimental models has also been done with more promising results. So here, this is the cornerstone of the intrauterine treatment, that it is the randomizer trial that was published in 2011. And it's called MUMS, the Management of Myelomeningocele Study. It's a landmark paper that shows us, we can put like that, all the results, and in a gold standard pattern, because it's a double-blind study, class 1 evidence. It's very important to know that the prenatal evaluation is the basis of our decision. So the ultrasonograph, it's very important. It should be done by specialized team, an experienced team, looking for some special features such as the banana sign or the lemon sign that are ultrasonographical evidence of myelomeningocele. Here we can see the lemon sign, the Sicilian lemon, you can put like that, in which you can see the retraction of the frontal bone. due to the hypotension, liquoric hypotension that frequently occurs. We also have the availability of the fetal MRI, but it's not it's not very easy to get access to fetal MRI, especially in our reality. So we base our prenatal evaluation in the ultrasound. So we have some inclusion criteria that comes from moms and that we strictly follow in our daily practice. So we might have a single fetus. The defect should be between T1 and S1, the presence of hindbrain herniation, the gestational age between 19 and 26 weeks, a normal karyotype, and the maternal age should be over 18 years old. So these are the main results of the MOMS study, in which we have the main result is the decrease in the placement of shunt percentage. So here we can see that in the prenatal group, we had 40% of shunt, and the postnatal surgery, 82% of shunt placement. And a reversal of the hindbrain herniation in the prenatal group. As we know, shunts, they bring with them a lot of problems, obstructive and problems, infectious problems, and sometimes even hair complications such as this one that we published, a vaginal cerebrospinal fluid discharge. And we know that we should avoid, whenever possible, the shunt. So as Professor Schuch says, the best shunt is, if possible, no shunt. But we cannot forget that sometimes shunt is the only alternative. For example, some years ago, we had an outbreak of Zika here in Brazil, and from in our region, we had almost 400 cases of Zika in central nervous system, and amongst them, 23 patients needed to treat hypertensive hydrocephalus. We don't know the exact physiopathology, but we needed the shunt for this kind of patient. So shunt has its role, still has its role in pediatric neurosurgery. We published it in the JAMA, our experience with Zika. But we also know that we have nowadays the endoscopic third ventriculostomy. This is our experience. We recently published more than 200 endoscopy procedures. And when we look for our subgroup division, we can see that myelomeningocele groups, they do not respond very well to ETV, not as primarily treatment. This is a controversial topic in the literature, but in our experience, we think that for myelomeningocele patients, ETV is not the first option. It's a great option if you have a shunt failure, for example, in older children, but not for a first treatment for myelomeningocele hydrocephalus, perhaps because the physiopathology is a multifactorial, and there is no reliable anatomical landmarks, which brings more difficulties in the ETV. So we also need to keep in mind that the intrauterine treatment of myelomeningocele has some problems, some maternal complications, and some fetal neonatal complications. So we do not have low levels of complications. As we can see here, there are several risks in this procedure that we might account, and we might clarify to the parents also. About the obstetrical technique, here we use the open technique, the hysterotomy, And we do a wall opening with an expanded fan steel, expose the uterus. We position the fetus with ultrasound, transop ultrasound, the fetal anesthesia, open the uterine wall, then we do the fluid replacement, and then we close it. So it's very straightforward. Our fetologists here, they try to do what has been called in the literature the mini hysterotomy. They try to do the smallest incision as possible in order to avoid premature labor or complications in the uterine wall. And sometimes it's very hard for us in the pediatric neurosurgery because there is a limited amount of space and it might be a little bit uncomfortable in the beginning. In my personal opinion, I think that the minimally invasive may be maximally dangerous, and it's not only in pediatric neurosurgery, but for everything. And this is something that I bring from Professor Bricolo, my Italian master, because he used to say to me, minimally invasive can be maximally dangerous. So I think that we need to do an enough opening, and that's one of our clash points here. We always try to open enough. If you have a big myelomeningocele, sometimes if you do a small opening, you might have some problems in terms of field. This is a small video in which we show how the procedure is done. It took us almost 2 years in preparation before we do the first case, several meetings, multidisciplinary team. And then we were trying to do a low-cost surgery because we are poor country, poor region. So we tried to adapt some disposable, let's put it in that way. And we were able to do it. This is the fetal anesthesia guided by ultrasound. And after the exposure, and the fetologist try to position the fetus. And after that, we do some holding stitches in the uterus. Sometimes the size of the uterus varies with the amount of amniotic fluid. If you have polydramnios, it will be easier. Here they are exposing the amniotic sac. It's a very tense point of the surgery because they need to keep the sac intact, and they are opening the amniotic sac, and they're going to stitch it to the uterine wall. So they're going to stitch it to the uterine wall. And this is already after the closure of the myelomeningocele. So we try to use the microscope, but sometimes we use the loops. There is no problem about it, but always, if possible, we use the microscope. In terms of neurosurgical technique, we never tunelize the pacodium. We always close we always try to close the dura mater. It's very important to close the dura, because if in the cases in which you cannot close the dura, there is a higher risk of complications, especially CSF leakage or even wound descents. So we try to close the dura mater. Sometimes you need to bring it with the fascia, and sometimes with the muscle layer. And then we close the skin, and we use absorbable sutures for that. So what make us a reference center? We are the main hospital complex in Brazilian Northeast region. We have 214 pediatric beds, 1,200 services per month, and almost 500 pediatric neurosurgery surgeries per year. and more than 40 medical residence programs, which is important because it's not one man's work, it's a teamwork. And this is our hospital, and it's essentially it's a general hospital, but it started as a pediatric hospital. So we have a very nice structure. This is a painting from a Brazilian artist called Portinari, and in here he depicts the misery in the migrants, the people that came from our region to the southeast region, the richest region, looking for better life conditions. So let's keep in mind that we have in Brazil nowadays pre-pandemic numbers, 16 million people living in extreme poverty, which means they live with less than $2 per person per day. And from these 16 millions, we have 9.6 millions in our region, in the Northeast region, which is almost roughly the Swedish population. It's a lot of people. So that's what poverty sometimes brings us. Complex malformations, it's very important to know that every myelomeningocele is unique. You have the same pathology, but different presentations. So we need to consider the amount of skin, the size, and the level of the defect. And it's always very challenging to face it. And this evaluation should be done preoperatively in terms of prenatal surgery. In terms of results, we have 51 cases. We started in 2014 up to now. We do 100% public health system, free of charge for the patients. We had 1 neonatal death due to sepsis, premature labor. 3 patients needed VPS, ventricular peritoneal shunts, no maternal death, and 1 CSF leakage that we had to repair postnatally. Some cases, the first case, it's a 28-year-old female, second gestation, second pregnancy, 25th week. In the ultrasound, the myelomeningocele, low 1, L4, L5, 3 per 3 centimeters, normal karyotype. So this is the prenatal ultrasound, in which we can see in the sagittal view the low myelomeningocele. Sometimes it's impossible to predict the amount of skin, and this is something very stressful sometimes because you might have a small myelomeningocele with no skin, and you might have to do a skin flap. And this is the procedure, same technique. We use a phenocyetal holder to expose the fetus, and micro instruments to try to close the defect. So this is in the labor. It's very important to check the uterine wall to see if there is no rupture at all. And this is the joy of the obstetrician team when they see that the patient's okay and with the defect closed. And that's pretty much the aspect of the postnatal result. And here in the outpatient clinic. Case 2, 33-year-old, first pregnancy, 26 week, even lower myelomeningocele, L5S1, smaller one, normal karyotype also. So here you can see the axial and the sagittal plane, the same lemon sign and the banana sign. Here the lemon sign in the inferior right picture. The frontal bone is retracted. And here the same thing, the whole time the ultrasound monitoring, and the obstetricians they are trying to locate and to position the fetus. Sometimes it's very hard. Sometimes it demands some maneuvers to bring him in the right position. And it's also a stressful moment because you can have bradycardia, and that's the importance of use the ultrasound. So this is a low one. You can see the uterus and after the closure. The last case is a younger one, 21-year-old, first pregnancy, 25th week, also a low myelomeningocele and normal karyotype. So here we are also exposing the uterus and trying to do the smallest incision as possible. So this is a very interesting article published recently in which they do a critical look at the whys. Why should we keep doing this kind of surgery? And it's very important to highlight that before we start to do this, we need to have a multidisciplinary team, a reference center, and all the conditions of and support for the mother and the baby. This is the recently published experience from São Paulo group. They started before us, so they have more experience, biggest number of cases, and the results are very similar to ours. So, but at the end, we have some unanswered or partially answered questions. For example, the ventricular size over 15 millimeters, the atrial measurement, influences in postnatal shunt rates. In our series, we think that, yes, it has an influence. From our 3 patients that went to VP shunt, at least 2 of them had the atrial measurement over 15 millimeters. But it's something that's not a consensus, because in myelomeningocele, we have a colpocephaly pattern, and this is due to the partially agenesis of the corpus callosum, and thus the already size of the atrium is going to be bigger than the regular atrium. And this is a matter of debate. What's the real impact over urological status in both pre and postnatal groups? We don't have this answer yet. What is the cost comparison between the 2 groups, especially in long-term evaluation? So what is the real maternal psychological impact of the prenatal surgery? And also, what is the real accuracy of the ultrasound in defining the anatomical level of the injury compared to MRI? So these are some questions that we still have no answers or partially answers. So what the future brings to us, we don't know. Maybe stem cells, maybe a progress of the fetoscopic technique. We are trying to start the fetoscopy, but we still think that it takes a longer learning curve, also more disposable materials. And also, we think that it's very hard to perform a multi-layered closure of the defect as we can do in the open technique. But we also need to look forward to better techniques with less risks for the mother and for the fetus. And at the end, it's very grateful to see how these children, they develop and they don't have the consequences of the use of the VP shunt. This is the main reason for this surgery. And I think that we have a long way to follow in order to clean up the doubts that these procedures brings to us, and the impact in the living of these children. So once again, it's a multidisciplinary work. we need to have all people involved and daily basis discussion about the results and about the techniques that we use. So thank you very much. Hope to see everyone soon after the pandemic, and invite you all to come here at Recife to visit our city. Thank you very much.
Very good.
Yes, Professor Diroko, any comments?
Yeah. My comment is every time the comment that I do in the last years concerning this problem. There is no doubt that several children can have a big advantage of this type of surgery. But the general advantage to me is overemphasized. And obviously, this overemphasis is not coming from people like Facchini, who operate for free in public hospital. It's more easy that they come from a hospital that receive a lot of money for doing this operation. So they tend to not see the things like they are. And this started since the beginning. The first comparison about the incidence of hydrocephalus was done with the rate of shunt in myelomeningocele before the advent of the intrauterine surgery. So in the paper, and every time they say XX rate versus 80% of children operated after birth. And which is not true, because nowadays the rate of shunt is 60%, no more 8% in all the centers. And this obviously, if you tend to avoid the shunt in a mild or borderline hydrocephalus, you can avoid easily if you decide that you want to avoid. While in the past, there was a tendency we should operate also the mild hydrocephalus if we want to improve the intellectual outcome. So what I would have expected in so many years is that, okay, we can give you the real figures, how many shunts we inserted in 5 years, 10 years. And these figures are still missing. In the same time, other advantages that were claimed, like improvement in motor on urology function, were not confirmed compared to the previous paper. And you have noticed that Igor said just this, and he was very honest, saying that there are some things that we can improve, obviously carry two. Maybe we can decrease a percent of the hydrocephalus, but we have still some things to learn and to understand. The other point that I want to stress is that he did this operation in Recife. He did by himself, so he learned by himself. He created a team, and this is very important because he can show to all the world that it can be done in every place in which there is a good center. That was something, things that at the beginnings after the operation in America, it seems that all in America could be done. Nowadays, this operation is done in all the countries, rich and poor, but still, and Igor can contradict me if he has some figures, still I am not clear the real impact on the incidence of hydrocephalus.
Well, I think that Professor Di Rocco, I totally agree. I think that we should always look at the numbers. We should always revise our experience. I think that we should always be critics of ourselves. If what we are doing is has a really an impact, I think that not every myelomeningocele will be treated prenatally. We are starting to do a study in which we compare the postnatal patient, the same pattern, with the same pattern treated prenatally. But we still don't have the data. Perhaps in the future we can come here and say, oh, let's not do it anymore. Let's get back. Let's get back. Yes, let's get back. But I think that you told about one really big issue, which is the money issue. Sometimes you have this kind of surgeries, they involve a lot of money. So it's something that you have a bias, even if there is a bias. It's something that we need to consider. In our practice, we do not have this bias, so we have a disadvantage in terms of research. But I do agree with you 100%. And we have all the myelomeningocele from a population of 56 million people. Not all, but from 10 million people from our state and 56 million from the region. Some part of these patients come to us. So, and even like that, 6-7 years, we only had 51 cases because we follow strictly the criteria of the moms. And sometimes I don't know how some centers with smallest population has so many cases, or what's going on. But I think that it's that there's a lot of questions to answer, as you mentioned and as I put in the presentation. But I think that it's a valid discussion.
And the second point is that after birth, you operate all the children, while before birth, you make a strict selection. So there are two populations that cannot be compared. For this reason, I think that the initial study was quite defective with the strength of America. And you see that I'm a little warm in this, just because after this type of studies, people can believe that if they don't have their child operated in utero, they are going to lose a lot. So they create this sadness in the mother. I don't have money. I could have been a lot better because 80%, blah, blah, blah. So this, I say this as an ethic problem, which already has nothing to do with your presentation. If there are no questions,
I would like to ask Professor a few questions, Professor Facconi and Professor Di Rocco. Thank you very much for bringing in insights into the technical and ethical issues largely at hand during this procedure. Professor Facconi, I would like to inquire from you how difficult it is for you to convince a mother to undergo 2 surgeries for a single baby.
Oh, how difficult it is to do the surgery?
No, to convince the mother of a child.
Yes. It's
he has to undergo 2 surgeries for a single baby.
Yes, it's I think that we have a psychological team, the obstetrician team. They have this first link with the family. The first link always comes from these specialties. And it's very important to clarify the mother, to explain the risks. Some of them, they do not choose to do the surgeries, but what we can see in our routine is that those that decide to do it, they do not regret. But this is our reality, cultural, religious. This is Brazilian, and specifically in our region, reality. This cannot be transferred to other countries. As Professor Di Rocco said, there are so many individualities that we need to consider. For example, here in Brazil, abortion is forbidden by law. So it's very hard for the mother to face with congenital disease, with so many problems for the whole life of these children. We used to say that the only two persons that keep with these children are the mothers and the pediatric neurosurgeon, because all the others, they go out of the way. Okay, even the fathers, sometimes the couple split and only the mother and us. So it involves a lot of issues. As I told, the first slide was that, because this is the bottom line. In your question is very good about it, because perhaps in India it's a completely different process to try to, we're not trying to convince the mother. Perhaps this is not the right word. We try to clarify them. We like a light, you know. We show the light, we show the paths, and they have to decide. I don't think that we should convince anybody of that. We should show the treatment, the outcomes, and put our opinion, but also listen to the families. It's very important.
Thank you very much. Surprisingly, stories are almost same throughout the world, where babies like this, the father abandons, and ultimately it is the job of the pediatric neurosurgeon and the mother who stays back. You're absolutely correct. Another question is like, after conceiving after delivering a baby who had a myelomeningocele and intrauterine repair, what are the chances of the mother of delivering a normal baby through vaginal delivery in the subsequent pregnancies?
We have cases in which the mother had intrauterine surgery and then after had another pregnancy and then normal labor, not a problem. But there's always the risk of uterine rupture. It's something that we clarify to them. So it's when we do this kind of surgery, we are leaving a mark in these mothers. So they need to be followed by obstetrician the whole life, especially if they decide to have another pregnancy. And much more important than that, I think that it is the folic reposition intake. So if you have a myelomeningocele case, so the rates of having another baby with myelomeningocele, they are higher. So the genetic counseling and the reproductive outpatient clinic have important role into clarifying these women. And a very important topic that Professor Di Rocco told is that this is something that I think that Professor Dominic Thompson from UK, he already said that sometimes when you have a baby with hydrocephalus due to myelomeningocele, sometimes you can wait a little bit. You can wait a little bit and not put the shunt immediately. Sometimes you won't have this hydrocephalus going faster, and sometimes you can avoid the shunt. So that's why I think that the rates are not 80% anymore. They are more around 60%. If we are not so much aggressive in terms of putting the VP shunt immediately after the birth in patients non-treated intrauterine, I think that you might reduce the amount of VP shunt. And this is our daily practice too. When I have a patient with myelomeningocele that didn't have the criteria, or this is very important too, sometimes the pregnancy, they don't come to us in the right time. We need them to be with us up to 26th week. And this is not the rule. In our reality, sometimes when they come to us, they already have 30, 32, 33, and it's not possible anymore to do any kind of prenatal treatment. So in this case, we in this case, in the postnatal group, we also are very conservative in terms of shunting. we do not have answers for that. We don't have a pattern to clarify and say, oh, you should do it or do not. This, I think that you can feel the patient, you need to see the children, and before decide to insert a VP shunt.
Thank you very much. One question from my co-host Liu Bun Seng.
Thanks, Raja. Thank you, Professor, for a very interesting discussion and talk. Professor, I want to find out from you that since you are only utilizing ultrasound, do you face that you miss other form of spinal dystrophism in those children, or you think that or all of them is just purely leaking myelomeningocele? And is the early repair that can prevent a neurological progression? Are they patients that still progress with a neurological deficit despite early repair due to the abnormality to the nerve itself? It's not only a non-closure tube, but also the nerve itself are pathological. Thank you, Professor.
Well, we rely on ultrasound because it's cheap. You can have it anywhere. It's very different. We have MRI in our service. We have MRI, but it's much more complicated to perform. And so we reserve the MRI for the cases in which there is some kind of doubt in terms of prenatal diagnosis. But we have a specialized team, specialized physiologists with huge experience. As I told you, it took us 2 years and a half before starting doing the surgeries. And so today we think that the ultrasound is very reliable tool. As I told you also, sometimes you cannot analyze the amount of skin with the ultrasound preoperatively, but you cannot do this either with the MRI. So sometimes the problem might be the lack of skin, the lack of tissue to closure. And sometimes we had to do a lazy ass flap or a Lindbergh flap. Sometimes we need to do this. We avoid to use heterologous material such as artificial dura mater. We do not use that in this kind of surgeries. The second question I didn't understand. Could you please repeat?
Does the early repair do actually always prevent progression of the neurological deficit at birth, or you think that there are some doesn't happen because of or abnormal pathological of the nerve itself rather than the neural tube per se? Thank you, Professor.
Yes, there's some problems that I'm not sure that the prenatal treatment will repair. For example, as Professor Di Rocco told, also the urological status of these children. We are not sure that the prenatal surgery has an impact over that. In terms of motor function, it is debatable. We have some papers that brings us some light in terms of better motor function, but I'm not completely convinced. I'm more convinced that the surgery in terms of physiopathology reduces the rate of shunt dependence. But I'm not completely sure for other functions such as motor function or urological function. There's a lack of studies. We cannot state that. We cannot put it that way yet. Perhaps in the future.
Thank you very much, Professor.
Thank you very much. With that, we can conclude this session and hear the concluding remarks from Professor Di Rocco.
Oh, I think that was very enjoyable because there was no some prejudice. We tried to understand the things, and I want to close to the fact that there were several studies in which to simplify surgery, and the people closed the defect with some foreign tissue, some all kinds of materials. And also they did by fetoscopy. So just going endoscopically and attach the covering. And also all this failed. So I think that what is important that Professor Queen said that you have to rely on the most reliable way to close. And I think it was also very serious. It's a presentation. Best regards to Professor Azevedo. And okay, thank you. And thanks to all the people.
Thank you. Thank you very much.
Professor.
Thank you very much indeed. With that, I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers of today, Professor Mehmet Zileli and Professor Igor Fekuni, as well as the chairs, Professor Onur Yaman and Professor Kanzesi Diroko, for their time and support for the educational initiatives of the ACNS. A very, very special thanks to Professor Shubin from Shanghai for airing this webinar on the WeChat channel. And we have more than 500 viewers who are viewing this live right now. A special thanks to my co-host, Dr. Liubun Singh, for joining in today. So until we all meet tomorrow, it is bye-bye from all of us. Thank you very much for joining.